This is Chris Jackson. I'm an assistant professor of neurosurgery at the Johns Hopkins University School of Medicine, and I'll be presenting Chapter 151, Basic Principles of Cranial Surgery for Brain Tumors, written by myself as well as Drs. John Weingart and Henry Brim. The objectives of this presentation and the accompanying chapter are to provide the reader with an understanding of how the preoperative evaluation of a brain tumor patient, in terms of the clinical history, the physical exam, and imaging findings, inform the treatment approach and the goals of surgery. Despite the diversity of brain tumor pathologies, these patients can be approached through a relatively common and simple algorithm to help guide management. Second, the reader will be able to select the optimal approach for achieving the goals of surgery, which are maximal tumor resection while avoiding neurologic morbidity. Third, the reader will have an understanding of the benefits and limitations of adjuvants used in the operating room, such as frameless stereotaxy, intraoperative MRI, and intraoperative ultrasound, for achieving the surgical goals stated above. Fourth, the reader will appreciate trends in steroid and mannitol use. And finally, the reader will become familiar with common postoperative complications and their best management. The evaluation and treatment planning for a brain tumor patient is based on the clinical history, a thorough physical exam, and evaluation of available imaging studies. As the surgeon collects these data, they should seek to ask the following questions. 1. What is the most likely pathology of the tumor, and what are the other possibilities? 2. Does the patient need surgery, or is observation appropriate? If surgery is indicated, is the indicated procedure an open resection or a stereotactic biopsy? 3. When should the surgery take place? Is there any urgency? 4. What other radiologic or laboratory studies are necessary so that I can be maximally prepared to perform the surgery? These questions are in fact a structured way of forming hypotheses about the underlying biology of the tumor, its rate of growth, and its risk to surrounding brain structures. As these questions are answered and one transitions to treatment planning, the surgeon begins to hypothesize about whether the tumor is malignant, benign, or non-neoplastic. High-grade malignant tumors may be associated with a past history of cancer and/or relatively rapid onset of symptoms, which are corroborated by the clinical exam. Radiographically, high-grade malignant tumors may be associated with extensive edema, enhanced with administration of gadolinium, and have areas of necrosis. Low-grade malignant tumors may appear infiltrative and are associated with minimal or no edema. Benign tumors are more frequently extraaxial and can often grow to a large size without producing significant symptoms depending on their location, as their slow growth affords the surrounding brain tissue time to adapt. Non-neoplastic lesions include inflammatory and infectious etiologies. This may be suspected in patients with a clinical course that does not fit well with the location and appearance of the lesion, or patients who have a history of inflammatory infectious disease. If a non-neoplastic etiology is suspected, the surgeon should consult with neurologists and infectious disease specialists to determine if a biopsy is necessary to make a diagnosis. Once the surgeon has determined that a tumor is likely to be malignant, they must identify the primary source of the patient's symptoms. Patients with significant edema and relatively small lesions can be temporized with high-dose steroids while surgical planning takes place in an elective fashion. Conversely, patients with a large mass and relatively little edema who have symptoms suggestive of elevated intracranial pressure may require more urgent surgery for decompression. If a tumor is located in a region where resection would result in unacceptable morbidity, needle biopsy should be considered. For a tumor suspected to be benign, asymptomatic lesions are often monitored with serial MRIs, which are typically spaced 3 to 6 months apart initially and may be spaced at longer intervals if they've demonstrated stability over a substantial period of time. Lesions that demonstrate growth or become symptomatic are reevaluated for treatment, either in the form of surgical debulking, radiation therapy, or both. If the patient is taken to surgery, gross total resection is achieved, and the tumor is determined to be without atypical features and pathology, then additional treatment is typically deferred, and the patient is monitored for recurrence with serial imaging. If the tumor is subtotally resected, depending on the location of the tumor, the pathology, and the patient's symptoms, upfront radiation may be offered. For subtotally resected tumors in which radiation is deferred, serial imaging is used to monitor the tumor's growth. We'll next review a series of cases to demonstrate how the algorithm is applied. The first case is a 22-year-old female with no significant past medical history who presented with transient, mild left facial weakness. During workup, she underwent an MRI, which demonstrated a mildly expansile, non-enhancing lesion centered in the posterior aspect of her left superior frontal gyrus, and there were no additional lesions identified. Given that this left-sided lesion would not be expected to produce left-sided facial weakness, and that her symptoms were atypical in that they were transient. She was sent for a thorough neuroimmunology workup, which was ultimately negative. After a thorough discussion of these results, the patient was offered surgery or short-interval follow-up with imaging. She opted for short-interval follow-up with a plan to undergo surgical resection should the lesion change in size or character. An extended history for the patient revealed that she initially noticed mild asymmetry of her face while looking at herself in the mirror, and that this resolved by the time that she sought medical attention. Her exam was nonfocal, and her imaging was consistent with an indolent process, as the lesion demonstrated no gadolinium uptake, did not exert local mass effect, and was not associated with edema. The most likely etiologies were non-neoplastic or low-grade glioma. Non-neoplastic etiologies include developmental abnormalities such as cortical dysplasia, although this was deemed to be less likely in this case given that the lesion appeared to be mildly expansile within the gyrus, or inflammatory pathologies such as multiple sclerosis. Therefore, she was sent for a neuroinflammatory workup, which was negative. These results were discussed with the patient, as well as the possibility